Good day. It is an honor and privilege to talk with you today about traumatic sensitization and the victim dilemma. Sensitization is opposite to adaptation. That is, when being exposed to something makes us more vulnerable to it rather than less. Trauma sensitizes. So do stimulant drugs, which cross-sensitize with trauma. Strangely, so can knowledge. Normally, knowledge is power, but knowledge of trauma, strangely, feeds into a phobic mindset of try to avoid trauma at any cost. We try, but are becoming ever more sensitized. Soon after the 9/11 attacks, the Institute of Medicine published a monograph that deemed traumatic sensitization to be a prime societal vulnerability and challenged us to build resilience. But instead, we're becoming ever more sensitized, with students even seeking safe spaces from everyday hurtful remarks. How, why, and what to do about it? A victim dilemma is incredibly complex. Victim simply means a traumatized person, but victimizing and victimhood are more fraught. 94-year-old Holocaust survivor and practicing psychologist Edith Eger distinguished victimizing as all too real and best prevented from victimhood, a traumatizing life position that's under voluntary control, which she repudiates in favor of agency and accountability. Co-survivor and psychiatrist Viktor Frankl wanted a West Coast statue of a responsibility to complement the East Coast statue of liberty. Both of them embraced as fundamental agency and accountability, fundamental to healthy humanness. Agency is the experience of free will, of perceived controllability, or the ability to make things happen. Accountability is recognizing whatever one does with it and its consequences. Helplessness negates agency and accountability, and hence is a prime ingredient of trauma. Helplessness before a mortal threat virtually defines trauma. And helplessness before one's symptoms is what makes them a mental disorder that needs expert help. Enhancing agency is both preventive and corrective. As a vaccine, when parents teach children how to deal with bullies, this makes them less vulnerable. All effective treatments somehow help patients to reactivate their agency. Associated questions are, when do our efforts help? How can they sometimes inadvertently worsen trauma, which they sometimes do? How to shift from sensitization toward healthy resilience? Pre-developed competencies persist after trauma, often hidden and heavily defended, but still active. Well-intended misdirection can threaten them with unintended complications. Alternatively, they can be accessed and utilized toward therapeutic recovery, building resilience. Hence, hidden agency is a key to either complications or recovery. This is huge. Also huge, relevant data are known but underattended. Strangely, we appear to actively avoid what we most need to know, actually do know, but act as though we don't. Here are some such data. Traumatic avoidance and reenactment doubly sensitized. Trauma marks personal identity. Contagion is mediated by hypnotic-like mutual suggestion. Trauma polarizes us versus them. Agency is hidden but active. Polarities often conflict, and to attend to but only one pole without the others invites unattended complication. Now let's look at these one by one. Traumatic avoidance and reenactment both undermine autonomous strivings. Avoidance makes sense, basic survival. But why do so many trauma victims feel compelled to reactivate the very traumas that they're also trying to avoid? Freud struggled to make sense of this perversity, as did Lenore Tur. Subsequent neurobiology data now offer a useful heuristic. Avoidance is driven by a maximally aversive traumatic affect that's mediated by adrenergic agents, which also sensitize. Two different processes drive reenactment. Dopamine is maximally rewarding, like the rush of combat, but also sensitizes. Two, one becomes physically addicted to endogenous opioids that are heavily secreted during trauma. Then, if one fails to reenact, opioid withdrawal further activates the sensitizing adrenalines. This dual sensitization gives trauma a life of its own, which conscripts victims into its service. There's no escape, unless one voluntarily abstains from reenacting. If one does abstain, extinction slowly occurs, probably through learned prefrontal suppression. Surprisingly, voluntary abstinence goes AWOL in today's treatment manuals. Why? Though difficult, it can be done, and relief often follows and can be quite dramatic. Traumatic identity can usurp one's personhood, with identity in scare quotes to note that we humans attach our life instincts well beyond physical bodies to abstract identifications. Only we humans are willing to die and kill others for some favored abstraction. Trauma indelibly marks one's identity as always different, though not necessarily worse. My father was an Iwo Jima veteran, much more than an insurance executive, for example, despite the battle's comparative brevity. Quite important, avoidance and reenactment may conscript one's identity into a so-called false self, which is often a therapeutic target that's defended like life and death at the expense of one's own true self-strivings. Individuals and society's traumas reciprocally shape one another. Though seemingly fixed, traumatic identities are socially malleable, and positive reframing can help them shift toward healthy agency. Victimhood identities are a particularly problematic subset of these, widely sought, often celebrated, and strenuously defended. But one huge problem. Victimhood implies persecutors and rescuers, a prime recipe for conflict. And all three roles, interestingly, can alternate within any given person, all stoking the trauma. Beware of fraudulent victim narratives. For example, Vietnam War stories were endorsed and defended so widely that they fed into a falsely negative social stereotype. Victimhood claims have been known for ages to rationalize much large-scale evildoing. Hence, victimhood is a prime target for intervention. Trauma is also contagious, spreading and displacing others' pre-existing thinking. Hypnosis informs such process, linked with trauma ever since the late 19th century. Personal identity, mental states, free will, are all modified by hypnotic suggestions that act from the outside inward and are only rationalized after the fact as if they were mental fundamentals. Although hypnosis is the most researched psychological data set, its massive data remain unknown even to many mental health experts. We're always unknowingly exchanging suggestions, which mutually interact toward either trauma epidemics, wars, and crusades, or more positively to collective pro-social norms. Formal hypnosis is somewhat problematic by occasionally unintendedly misimplying less subject agency. I personally know colleagues who unwittingly reenacted trauma while trying to relieve it, with disastrous consequences, probably by promoting victimhood through well-intended rescuing. Better, therapists should know enough hypnosis research data to be able to recognize, reframe, and redirect spontaneous hypnotic processes when they occur away from traumatic reenactment toward healthy agency. Traumatic polarization further clarifies things. When I chaired Psychiatry and the Law's Recovered Memory Committee during the late 1990s, I interviewed opposing experts. They all began sharing values of child protection, treatment for victims, family integrity, and the presumption of innocence. But trauma marks its content's salience, the gist, at the expense of peripheral details. If one's worked with child abuse, child protection becomes salient, family integrity be damned. But if innocent families were broken by dubious allegations, then it's the child advocates who become the evil subversives. Poles pull apart. Conflict becomes intractable. Whoever I was speaking with, I felt a compelling pull to join a beleaguered us against an evil them. Reenactment was the interim victor. Now, when we see a system destabilize, most of us would ask what counterforce is missing. With trauma, it's usually agency. In order to appreciate how competencies can go missing and then wreak havoc, note how the experienced helplessness of traumatized patients both resembles and differs from the intrinsic helplessness of distressed infants. The two resemble one another in both the experienced helplessness and becoming accompanied by aversive adrenalines in the infants or victims, their caregivers, and third-party observers. Providing relief comparably evokes self-soothing opioids in all parties. But traumatic and infantile distress differ in other key particulars. For infants, distress is uncomplicated and relief is absolutely essential for growth and development. But offering nurturant relief to trauma victims sometimes paradoxically destabilizes them. How? Unlike infants, their competencies had already pre-developed. They are still there. Although hidden and heavily defended, they continue to act, reenact, and sensitize, sometimes drastically amplifying trauma. Two difficult complications can follow. Regressive dependency sometimes complicates unbalanced therapeutic nurturance or rescue. Some distressed patients seek these, but when given, become more distressed, plea for ever more rescue, then act out against whatever is on offer. Early on, I developed a vicious circle model for this. Relief of distress feels good at the surface level. leading to a nearly insatiable dependency. But this dependency threatens one's already fragile hidden agency, creating more anxiety and hence more dependency in an escalating vicious cycle. The therapeutic corrective here is to challenge patients' hidden competencies rather than threatening them. Many respond positively, but a few others instead demand further relief at threat of dangerous acting out. Another complication. What then? Symptomatic coercion carries awesome social force. That is, if we don't prescribe some addictive drug or grant some special favor, we'll be held responsible for some truly bad outcome. Such coercion is enforced by threatened acting out and/or legal consequences. This is moral blackmail. Appeasement can lead to escalating demands, just as it does with military aggression, and sometimes can even reduce a therapist to utter subservience. But worse, direct counterforce also escalates. It's kind of like fighting fire with gasoline. The only true antithesis I know of is to stand firm against the coercion, withstand ensuing accusations, and always seek consultation. Sadly, therapists' expectations heighten these risks. All are aspects of doing therapy. Seeking an alliance can motivate us to validate victim narratives, polarizing them against perpetrators and rescuers. Being helpful tempts us to rescue distressed patients, sometimes destabilizing them. Liability for failing to protect terrifies all of us who face patients' symptomatic coercion. These anti-incentives wield awesome social force, and only ill-defined fine lines distinguish them from more therapeutic strategies that better access agency and accountability. Now, let's turn toward strategies for therapeutic mitigation. Communication style is first and foremost. Suggestive implications are pivotal and can either covertly imply helplessness and amplify sensitization, or imply competency and mitigate it. Here are some illustrations. Reframing affects the experience of agency. Consider two simple ways to seek an alliance. One, how can I help you? Is innocuous enough, but implies that I am the active agent, not you who needs to be. Two, what is your goal and how can my input be useful? Implies that you are the active agent and I'm a consultant, both truer to our intentions and more activating. Collaborating applies at many levels. The therapeutic alliance has profound effects all in itself, not well understood. Informed consent activates agency with information and can help with even actively psychotic inpatients. We also contract for specific roles. Who does what, for whom, how, and with what exceptions. It further helps to distinguish treatment from protection. They are separate issues, though often linked, they're separate. When not committed or incarcerated, patients retain the full locus of control for their behavioral safety. It's particularly helpful that they accept as much responsibility for this as they're able and willing. Can we trust them for this? Such negotiations are best begun in the very first session. If we're forced to protect them, we do so, but define this not as extra treatment, but as contrary to treatment by their own choice. Families are powerful adjuncts, and most patients give permission to work with them. When families' narratives differ, many patients still embrace them, thereby reframing. Other stories and mutual suggestions often converge toward an otherwise undetected focal point. In some cases, it's possible to change one party by working entirely with another. For example, substance abusers' families can impose powerful leverage by attending support groups such as Al-Anon. Reactivating trauma is controversial. Many, perhaps most experts recommend controlled exposure to traumatic stimuli toward therapeutic relief. Others note that this can reenact, paradoxically sensitizing further. Now, there are ample lines of data that support both of these positions. My own take is that it probably turns on patients' locus of control. Therapist rescuing can undermine it, covertly reenacting. Promoting patients' initiative better activates it. But making this decision problematic is the fact that locus of control is often hidden, unseen, but still there, active and pivotal. Accessing it requires therapists' clinical expertise, strong personal boundaries, and knowing the underattended hypnosis research data. Interdicting traumatic reenactment can starve the trauma response of its fuel, and strangely goes AWOL in current treatment manuals. We ask a particular patient relevant questions. Is there a focal reenactment pattern with addictive attributes? If so, is it within his or her locus of control? Is he or she willing to abstain? Surprisingly, answers are yes more often than one might suppose. Patients' challenge then becomes much like abstaining from addictive drugs. Terribly difficult, seemingly overwhelming, but possible. And when done, improvement can follow rapidly and be quite profound. Standing firm against symptomatic coercion puts the onus back onto us therapists. Here, we identify what's within our agency and stand firm against being forced off course. We decline demands for inappropriate favors and may face retaliatory accusations. This is particularly hard in today's climate of patient satisfaction surveys. Again, if we're forced to actively protect a patient, we do so, but define this as protection only and seek colleagues' consultation. Standing firm resembles abstaining from reenactment, equally difficult, equally important. Now turn to limit setting and the victim dilemma. Limits complement nurturance and go along with the accountability that Doctors Eger and Frankel urge all of us to embrace. Children simply can't be permitted to run into busy streets, play with fire, or assault one another. Limits become ever more specific as growing children become ever more competent. Secure limits are anti-traumatic in themselves and a matter of life and death for children who are at risk of becoming antisocial. But limit setting is also intrinsically aversive to all parties, to the person being limited, to the enforcer, and to third-party observers. To overcome this aversion requires the enforcer's confidence in the limit's necessity and goodness, which in turn depends on social support. Concordance can lead to massive societal well-being and functionality. Big problem. Enforcement can also become abusive, in which case it demands correction. Criminal law once did this, but no longer. What then? Anti-victimizing doctrines slowly superseded traditional authority structures beginning in the 1960s. Child protection exploded after Kemp's seminal paper on the battered child syndrome. Affirmative action qualified racial equality shortly after civil rights were mandated. Women's liberation dominated the 1970s, with former role variations now being permitted, widely accepted, and celebrated. Do these doctrines work as intended? There is evidence of less battered children, more minority successes, and women's empowerment. Why then does society seem to be exuding victimhood from almost every pore? There are potential trade-offs, and they are incredibly sensitive. Are there costs to children of capricious disruptions, such as one-parent households or revolving boyfriends? How is racial distress catching fire so heatedly while diversity is actually at its all-time historic maximum? Are pro-social norms possibly being destabilized by the weakening of nuclear families? Well, there are no easy answers. Blaming the victim accusations are often wielded against those who attempt to hold traumatized persons accountable. Sometimes it's simply necessary. We can best mitigate this risk by openly respecting others' right to differ and truly blaming only those people who knowingly and willfully violate the rights of others, some of whom were once victims. Now, I once asked a World War I veteran to compare the stresses of growing up then and now. His reply, always stressful, but we had it easier. We knew that life's rough, bad things happen, we deal with them and make the most of things. You guys have that crazy idea that things should be perfect. Yes, might trying for a perfect world have disrupted social norms that once underlain collective well-being and functionality. That is, the perfect as the enemy of the good, as Voltaire once allegedly said. If so, can we restore these challenged pro-social norms, hopefully without the abuse? Now we turn to two large-scale illustrations of these complexities. A recovered memory controversy illustrated irreconcilable conflict between victimhood and agency on a massive social scale. Patients were allegedly remembering child abuse in suggestive therapies after decades of non-recall. Many therapists joined an anti-victim crusade, shouting at a 1993 APA forum that recovered memories are necessarily true, alleged abusers therefore presumed guilty, patients require their therapists, and contrary research data are seditious. Many accused were convicted without physical evidence, and families were broken. And rather than relief, alleged victims' symptoms escalated, with regressive dependency occurring on a massive social scale. Once competent individuals were ending up in state hospitals, and opposing experts were getting death threats. Traumatic reenactment was the interim victor. This destabilizing process reversed after accused families and memory researchers founded an advocacy group and fought back by successfully forcing the courts to consider contrary evidence. Like all memory, traumatic memory turned out to be sometimes true, sometimes false, and always shaped by suggestive input. Corrective principles reemerged. Conviction again requires physical evidence, and optimum treatment builds on patients' strengths. How did this self-correction occur? Legal limit setting came first. Within 5 years, courts were awarding 8-figure judgments against therapists who had broken up families without provable cause. Therapists soon adapted, and most came to concur. Corrective information, shared narrative, and reduced reenactment all followed. Similar process might apply to other coercive mass traumatizations today. Now, let's return to clinical practice with more ways to challenge patients' hidden competencies. Accessing agency. Yes, but interactions occur whenever a patient asks help for a difficult problem. Others offer suggestions, patient defeats them all, then the others turn on him in a payoff that reenacts some trauma. Eric Burns simply turned the question back onto the patient. That's an interesting problem. How are you going to solve it? Thus acknowledging the problem, continuing the dialogue, but reaccessing agency. My own variation was to ask a patient's personal identity. Who are you? What do you stand for? Where are you headed? Try these on yourselves and find that it's hard to avoid changing in the process. Might such process enjoy yet untapped therapeutic potential? The big question was, can patients' agency and accountability become a primary treatment in itself, as opposed to simply being treatment's desired result? Can it be effective, efficient, and safe? Might it even be particularly helpful for disorders of extreme trauma, such as dissociative and severe borderline, who are so unstable that experts Alan Francis and John Clarkin even advised against their being treated? My messages were that I couldn't change them and wouldn't even try, thereby posing no threat to their hidden agency and instead engaging their active strategizing. My colleagues and I compared traditional treatment that emphasizes therapists' essential role with an experimental alternative in which patients were challenged to take most treatment responsibilities onto themselves. Then we assessed the comparative results using both the therapists and their colleagues' ratings, which proved reliable to approximately plus 0.8. Exploratory psychodynamic therapy, or EPT, provided a baseline or quasi-control for therapeutic comparison. Here, therapists embraced the traditional roles of being an agent of change and primary crisis resource. Therapy was said to occur during scheduled sessions in therapist's consulting room. Change was said to arise through traditional modes such as the therapeutic relationship, transference, interpretation, and some ego state work. The experimental strategic self-therapy, or SST, assigned most of these functions onto the patients. They were to assume primary responsibility for the direction and pace of therapy. Most challenging was to guarantee safety from the destructive behaviors for which they are so well known. Therapist's role was strictly limited to consultant, renouncing the roles of either doer to or primary protector. Absence of the latter required that an independent system serve as a crisis resource, most often an emergency room. Life itself was the consulting room, allowing for lesser frequency. Change was said to occur through contextual reframing, by patients progressively redefining their personal identities. Differential responsibilities were literally correct, though unconventional. Patients could do what only they can do, with therapists limited to being consultants. By not rescuing, there was no threat to patients' hidden agency, lessening regressive complications. Treatment and protection were explicitly separate, with patients solely responsible for protection and/or to seek it and accept it elsewhere if they were to come at risk. This is of pivotal importance. There were roughly two phases to SST. An engagement phase began with informed consent about alternatives, then contracting to all patients' roles and responsibilities. This process was challenging and ended only when mutual trust was established, particularly us therapists' trust for the patient's behavioral safety. There was significant testing en route, and at-risk patients used emergency rooms when needed, though sparingly. Patients' trustability was a precondition for proceeding further with this method. SST proper involved patients redefining their three identity questions. Self-description was like introducing a character in a novel. Value priorities was like one's personal manifesto. And one's plan included perceived roadblocks and backup strategies, emphasizing the word perceived. This could go in several directions and most often proceeded quite smoothly. Comparative assessment was of 30 patients in SST compared with another over 30 in EPT on several measures. There were three composite measures. These were regressive potential, self-therapeutic effort, and therapeutic progress, which was a blanket negation of DSM-3 mental disorder. All were reliable to around plus 0.8. Regressive dependency was unidimensional and thus somewhat more reliable. Other considerations. Data were shared. There were no random blind controls. EPT sessions were doubly more time intensive, and the SST population was somewhat more regressive to begin with. Comparative effectiveness data follow. Regressive dependency was reduced in SST, but didn't correlate at all with therapeutic progress, apparently a separate issue. Therapeutic progress was nearly equal in both modalities. SST was thereby doubly more cost efficient due to its halved intensity, but accompanied by a 27% dropout rate compared to almost none at all in EPT. SST was simply too demanding for some patients to stay with. But the upside was helping those 73% who some experts consider too unstable to even treat. After more experience, I slowly came to incorporate SST principles into more traditional treatment, particularly emphasizing patients' responsibility for self-protection, abstaining from reenactment, and redefining themselves. This led to better adherence and somewhat improved results, but was much harder to measure. Therapeutic progress correlated with patients' self-therapeutic activity almost linearly and significant to p less than 0.001 in both modalities. Correlation is not causation, nor is it entirely material here, as there is some overlap between the two measures. But experientially, it's quite profound. Most patients feel utterly helpless before their symptoms, but readily accept responsibility for whether, how much they do or don't pursue self-therapeutic efforts. That is, that which are involuntary symptoms in one reference frame are subject to voluntary choice within another. Thereby, via a complex societal reframing, traumatic helplessness is thereby shifted toward agency and accountability. Now let me conclude with the Institute of Medicine's challenge. Can we treat society's sensitization similarly? We're challenged to clarify who's responsible for what and hold all parties accountable for the obligations of citizenship. Standing in the way are aversion to blaming the victim, victimhood identities, and constricted discourse. More propitious options are well affirmed by the appellate courts, but underutilized and hardly even known. Legal duties of psychiatric patients are to provide accurate information and cooperate within the bounds of informed consent. Parameters of appropriate risk-taking are also enforceable and can be contracted on a case-by-case basis toward local standards of care. Finally, reopening discourse from traumatic suppression is absolutely essential and a yet unmet societal challenge. When recovered memories had similarly seemed to be immutable, advocacy and the law had provided correction. Jury research shows that just one principled juror can sometimes turn a self-reinforcing groupthink toward a more just verdict. This is the power of standing firm. Perhaps when enough of us come to stand firm against traumatic coercion and victimhood, the tide may turn toward the healthy agency and accountability of citizenship, and thereby shift from traumatic sensitization toward healthy resilience. That is the challenge posed by Drs. Eger, Frankel, and the Institute of Medicine. Thank you very much for your interest and attention.